All right. Hi, everybody. Dr. Hassaballa here. We're talking about hypoxic respiratory failure in the latest episode of Lectures from the ICU. All right. So, why do we have blood? Why do we have blood?
Circulate oxygen and nutrients through the body.
So, she says circulate oxygen. What do you say? Why do we have blood? What's blood for?
Yeah, I would say circulate.
To deliver oxygen, right? So, the blood is to deliver oxygen. So, that's exactly right. So, you can actually calculate, oxygen delivery. Like you can get a number of how much the oxygen is delivered to the tissues. There's a whole equation. So the oxygen delivery equation is cardiac output multiplied by the oxygen content of arterial blood. Okay. So what's cardiac output?
Stroke volume times heart rate.
It's heart rate times stroke volume, right? So it's heart rate multiplied by stroke volume. Anybody know what the oxygen content of arterial blood is? What the formula is? That's fine. Pulmonologists. Yeah. So it's 1.36 multiplied by hemoglobin multiplied by the oxygen saturation plus 0.003 times the PaO2. 1.36 is the number of milliliters per gram, milliliters of oxygen per gram of hemoglobin. That's just how many cc's of oxygen a gram of hemoglobin holds. Okay, multiplied by the hemoglobin, multiplied by the oxygen saturation plus 0.003 times the PaO2. That 0.003 times the PaO2 is dissolved oxygen in arterial blood. At sea level on room air, dissolved oxygen is negligible. We don't care about it. So the main determinants of oxygen delivery, given a fixed cardiac output, is hemoglobin and oxygen saturation. Okay? So we know where hemoglobin, how we can measure hemoglobin. Where do we get oxygen saturation from? How do we find oxygen saturation? Don't say pulse ox. That's not it. It's from the curve. Remember the hemoglobin oxygen dissociation curve? Remember that? That's where it comes from. The hemoglobin oxygen dissociation curve um, uh, graphs PaO2 versus SaO2. Okay. Once you're typically, when your PO2 is 60, your saturation typically is 90. Once you're at 90, you're on the flat part of the curve. Remember, this is called a hyperbola. Math, hyperbola have an asymptote. It'll never get to the asymptote. So once you're here, moving further down the plateau doesn't matter. Whether you're set 93, 94, 99, 98, 97, doesn't matter. Once you're above 90, you're safe. And most of the time, when you're above 88, you're safe. The danger is this steep part of the curve here. The danger of that part of the curve is because very small changes in PO2 have dramatic changes in SaO2. Very like 10 millimeter mercury on this steep part of the curve can cause a 50% drop, for example, in PaO2, SaO2. Now, remember, oxygen delivery is determined by SaO2 and hemoglobin. A 50% drop in SaO2 is very, very significant. So, once it's above 90, and for me, 88, who cares what it is? If it's 93, 94, 95, doesn't matter. So, but the whole thing is PaO2 on sea level, at room air, at sea level, is who cares? Is who I don't care. And remember how the curve shifts to the right and the left? Remember when remember what makes the curve shift to the right and shift to the left? So what makes the curve shift to the right is acidosis, hypoxia, or all these things. Mainly acidosis makes the curve shift to the left. Alkalosis, carbon monoxide, all those things make the curve shift to the left. What that means is the affinity of hemoglobin for oxygen changes. When you're acidotic, the affinity of hemoglobin for oxygen is less. So hemoglobin wants to give off oxygen more. It's much more easily. Okay, which means that you need a higher PaO2 in acidosis to get the same saturation. That makes sense. If you're acidotic, if your lactic acid is 11, okay, and your pH is 7.0, you want hemoglobin to give oxygen to the tissues. Okay, alkalosis is the other way around. Now, oxygen, hemoglobin binds much more tightly to oxygen. That's bad. If you're sick, that's bad. So in carbon monoxide, carboxyhemoglobin really holds on to oxygen, and so the tissues become hypoxic. But so, given the patient's current situation, a given PO2 can give a saturation of 88 in one moment, and in an hour later, the same PO2 can give a saturation of 95, depending on what we do to the patient. So I don't care about PO2. I don't care about, who cares about PO2? As long as so when you call me and say, Doc, the PO2 is 53, my next question is going to be, what? No. What's the saturation? Anytime you call me with a critical PO2, I'm going to say, what's the sat? Because it'll flash red. PO2 is 45. Danger! Oh my God, we're gonna die. What's the saturation? 91. Oh, okay. I don't care. I don't care what the PO2 is. Now, PO2. There's one time where PO2 matters. When would that be? There's one time. When do you think PO2 matters? So in carbon monoxide poisoning, PO2 matters. When you have somebody that comes in, for example, you have a family, a lot of them come in with mental status change because they heating their home with their stove in the kitchen. What do you think they have? Carbon monoxide poisoning. If you have severely high enough carboxyhemoglobin, what do we do? And they have mental status change and everything like that. What's the treatment? Oxygen is treatment, but what sometimes we do? We do hyperbaric oxygen. What are we doing in hyperbaric oxygen? We are dissolving oxygen in the blood. So now the PaO2 matters because I'm increasing the, that's why I kept saying at sea level, at sea level, at sea level, because atmospheric pressure at sea level is normal. But in a hyperbaric chamber, we're going to 4 atmospheres, 5 atmospheres. Now I'm driving oxygen into the blood. Okay? I'm driving oxygen into the blood, and then it matters. But at room air, at sea level, I don't care what PO2 is. So whenever you get a blood gas and you want to report it to me, you look at the PO2. Yeah, you have to report the critical PO2. But what's the clinician has to ask, what's your saturation? If it's 86, 88, 84, 83, yeah, then you have to intervene. But if it's 91, if the PO2 is 50 and the saturation is 91, it doesn't matter because you're on the safe part of the curve. Questions? Bottom line is, what matters to oxygen saturation is oxygen delivery is hemoglobin and saturation, not PO2. Now, there is something called the PF ratio. It even if the PO2 say is 100, okay, a PO2 of 100 on 100% FiO2 is very bad. That's severe hypoxia because of what's called the PF ratio. The PF ratio is PaO2 over FiO2. Okay? If it's more than 300, you should be okay. Between 200 and 300 is mild. This is the definition for ARDS, is mild hypoxia. Between 100 and 200 is moderate hypoxia, and less than 100 is severe hypoxia. According to the alveolar gas equation, okay, the alveolar gas equation is FiO2 multiplied by 760 minus 47, okay, minus the PCO2 over the respiratory quotient. All the normal on room air, the alveolar oxygen gas should be 100 on room air with a normal PCO2 and a normal respiratory quotient. Okay, so at room air, the maximum PO2 you should have is a 100. So if I tell you, hey, go and get a blood gas on room 17 off of oxygen. Sure, doctor. And then you go and you forget to take the oxygen off. And you draw the blood gas, and it comes back, and the PO2 is 125. And I say, was that a room air? Oh, totally. 100%, doctor. I know you're lying. Because of the alveolar gas equation. Because I know that maximum PO2 with no AA gradient is 100. Okay? So a PF ratio of 100 on room air is 100 divided by 0.21. That's 500. That's great, right? But a PO2 of 100 on 100% of FiO2 is a PF ratio of 100. That's very bad, right? So the PF ratio will tell me, yeah, the saturation may be okay, but they're still very hypoxic, which is important to know, especially in ARDS, pneumonia, PE. If somebody comes in clear chest X-ray, but their PO2 is 55 on room air, why? That makes you think of pulmonary embolism, right? Or they have ARDS, and you think, okay, I'm okay. The saturation is 92, but they're still very, very sick. So that's where the PF ratio comes in. But in general, PO2 doesn't matter to oxygen delivery. So when you get a blood gas, don't panic. Like rule number one in the ICU, don't panic about a low PO2. Especially if the saturation is above 90%, even 88%. That's the key of this whole thing, is that PO2 does not matter on room at sea level on room air. PO2 doesn't matter. It's not a determinant of oxygen delivery. Hemoglobin is, and now if you look at this equation here, what happens if you suddenly drop hemoglobin? Say you're bleeding and you suddenly drop your hemoglobin. What's the first thing that happens hemodynamically? You're going to compensate how? Heart rate. They become tachycardic. They become tachycardic because of this. Now suddenly your hemoglobin goes down from 15 to 8. To maintain a constant oxygen delivery, you got to increase cardiac output. What happens is the stroke volume goes down, so the heart rate goes up. So that's the first indication of a hemodynamic compromise. Very frequently, is tachycardia, sinus tachycardia. And the reason that is because of the oxygen delivery equation. So now you understand why the first thing is tachycardia. PE, not necessarily, because PE, the interaction of the clot with the heart can sometimes cause a reflex tachycardia. It may not necessarily be because of saturation, because you'll find that. You'll measure it and you'll see. But there also may be an element of tachycardia because now the SaO2 is down, and now they're trying to compensate by increasing your heart rate. Same kind of thing. But this is why. This is why. And if you look at any charts of oxygen delivery and hemodynamics, PO2 has nothing. It's not even there, because at sea level, it's dissolved oxygen is minimal. It doesn't matter. No, that's a great question. The question is, how about at high altitude? Well, you are hypoxic in high altitude, but why is that? Why are you hypoxic in high altitude? What's the FiO2 of room air in Colorado? What's the FiO2 room air here?
Higher than Colorado.
No.
Oh.
Nope. The FiO2 at room air at sea level is 21%. Okay. The FiO2 at room air in Colorado is 21%. Why are you hypoxic in Colorado? Why are you hypoxic in the top of Mount Everest? Room air is 21. Earth has 21% oxygen. Earth, all of Earth. Doesn't matter where you are, but you are definitely hypoxic in the mountains. Why? It's in the alveolar gas equation. You are hypoxic in the mountains because atmospheric pressure is not 760. It's a lot lower. So your maximum alveolar oxygen concentration, the partial pressure of oxygen in alveolus in the mountains is less than 100. That's why you're hypoxic. So it's not because there's less oxygen in the air. It's a very common misconception that there's less oxygen. Nope, there's the same amount of oxygen in the air. But in the mountains, there is less atmospheric pressure, so your alveolar concentration of oxygen goes down. It goes down. And so that's why you're hypoxic in the mountains. There, PO2 does matter because your maximum PO2 is not going to be 100. It's going to be whatever the calculation is up there in the mountains in Colorado or Mount Everest. I can't remember, but sometimes your maximum PO2 is like I don't want to guess. Much lower. You can calculate it from the alveolar gas equation. From the alveolar gas equation, you can calculate it. That's why you're hypoxic in the mountains, not because there's less oxygen. There's less atmospheric pressure in the mountains. So this is all first-year physiology. If you remember this, you don't harm patients. If you forget this, you may harm patients because then you don't understand. You may give someone oxygen because of a low PO2, even though their saturation is fine. That doesn't mean you shouldn't look to see why. Someone who comes in with a clear chest X-ray should not be hypoxic. Who has no lung disease, a healthy person should not come into the hospital hypoxic. That doesn't mean that I have to slam them with oxygen if their PO2 is 63 on room air. That doesn't mean they need oxygen, even though on the blood gas the number is red. Okay, so one thing, a PF ratio of 63 or PF ratio will be 300. Okay, on or 250 on someone with no lung disease coming in on room air. That's not normal. You should look for some. Why are they hypoxic? That doesn't mean you have to put them on BiPAP. And there's where knowing the physiology makes a big difference, so that you don't harm patients. That's the key. And that's it. That's all. That's my sermon on hypoxic respiratory failure.